Okay, so we've just got a couple of interesting cases of Cushing's to share today, and share with you the investigations that we've done and how we've managed their cortisol levels thus far. Neither have had surgery yet. So it cannot work. Oh, here we go. So the first patient is a 38-year-old lady who's a non-smoker and a non-alcohol drinker. And she came to us first in August after being seen in a district general hospital in July. And at that point, her weight was 108 kilos and she's 1.65 meters. She has a 3-year history of easy bruising, acne, hirsutism, and some pain at the top of her legs. She'd increased in her dress size from 16 to 20 over the previous year or so. And she does have a significant abdominal girth, and she had a significant increase. She has plethoric features and also has developed type 2 diabetes. She finds it difficult to climb stairs and to carry out daily activities such as loading the washing machine as she gets her arms get tired. When she came to us on examination, she had a round plethoric face with marked central adiposity and a suprascapular fat pad, no proximal myopathy in her upper limbs, although she had slight reduction in hip flexion, but she could rise from a squat. Her blood pressure is there, her heart size was normal, she had no purple striae, and her visual fields were intact to confrontation. So from her referring hospital, she had failed a low-dose dexamethasone test with a cortisol of 159, and her baseline cortisol was 750 with an ACTH of 95. So then we continued investigating. She had an overnight dexamethasone test. The cortisol level from that was 278. And in the table, you can see her late night salivary cortisol and cortisone levels, bearing in mind that the normal range for cortisol is less than 2.6. The normal range for cortisone is less than 18. Her IP, she then went for IPSS. This excluded a peripheral source of ACTH. So this is just a bit of a timeline with regard to her cortisol levels. So she started on the 7th of October, metirapone, after she'd had her IPSS. At this point, her cortisol was, after this, she started metirapone a few days before this, and we rechecked cortisol level. And so then she had a dose increased on the 12th to 750 milligrams at 6 p.m. So we do that to try and mimic a bit of a diurnal rhythm for these patients. The metirapone dose was then increased again to a gram BD on the 29th of October. And then in between, around the 28th of October, she was due for surgery, this lady, but she was found to have ICA aneurysms on her planning scan, so we had to abandon the surgery, had to be abandoned at that point. So she was then discharged on a gram of metirapone BD, and then you can see her cortisol levels there. We added in some potassium, and we stopped the indapamide and started spironolactone 50 milligrams once daily. On the 19th of November, she had the metirapone was increased to 1 gram TDS. This was following her balloon test for her aneurysms, and she was given prednisolone 3 milligrams once a day. She was seen in clinic.
Can we just see if anyone's got any thoughts about that? So to just go back to the beginning, the thought about, you know how cortisol is high in the morning, and no on that slide, so same one, Debbie, just that one, yeah. How what we'd like, of course, is a diurnal rhythm, and that means you have a high cortisol when you wake up, and it starts to rise at about 4 a.m. and then it drifts down through the day and it's low at midnight. All and because there's no protocol for that really, and of course the best treatment is surgery. And so one of the things that we thought we could try was give her metformin at 6, which will give her its peak activity at night, so that by midnight she'll have a low level, and then we'll drift upwards so she doesn't have a low morning cortisol. But it's really hard to achieve that because you can't measure it lots of times a day. You just get one measurement, and it's going up and down at the time of day. So
wouldn't it be constantly high in an adenoma? So that
yes.
So you won't really have the luxury of being able to control the level.
No, so you're right. So my thoughts are, this is just a thought, right? I'm not saying it's right or wrong. So let's say you have a tumor that's pushing out a fixed amount of ACTH.
Yeah.
If you block the adrenal gland in the evening, so it maximally blocks overnight, and then the drug wears off, you might, you might get a rhythm. You might have a lower level at night than in the morning. And if it was mild Cushing's, which this doesn't sound like it was really, to be fair, that might work.
Depends what
because
your goals are, because you want the area under the curve of cortisol not to be harmful.
Exactly.
And to achieve that, the question is, can you have some swings in it, or do you just have to bite the bullet and go for a level around 50 to 200?
Yeah. So that you can see what we were doing, because the problem is that without lots of blood tests in one day, you're in the dark. You just get a 535 at that time. Goodness knows when it was, at midnight. So we've ended up, as you can see, winding up the dose, and then eventually, having heard John Newell Price talk about block and replace, I thought we'll do that. And of course, we know that PRED3 is easy to, and that's used. And so you max, and it's working. The cortisol is now quite low. That would be marvelous. I would love to do that. Yes, that's the other option. And so that is so suppose she was local or lived or came into hospital, that would be very interesting to do. But
Would you like to do?
not now, because now she's on PRED, so it's easy.
Sorry, we just didn't hear the comments.
Sorry, the comment was, what about doing a day curve on the 7th of October? Supposing we had her in hospital, we could have seen if the late night dose suppressed it at night and then it slowly came up, exactly how. We haven't got the dynamics properly sorted out. So that would be quite a neat thought, really, for somebody, for one way.
I wasn't at the VES, so John Newell Price, you mentioned, was talking about block and replace.
Yes,
so default management, or
no, it was a COVID.
Very
Yeah, very COVID.
talking about COVID.
Yes, we're talking about managing, and he used that metyrapone and PRED3 for quite a long time. It was months, I think. Was it months?
Keep them safe.
They did pretty well.
Really high cortisol.
Yeah.
And
Angela has been like that. Oh, it was the thyroid lump, wasn't it? Yeah. Sorry? It was in that. Was it?
1 gram QDS.
Yeah.
With ending. He said initially it was 0.25 dex.
Yeah.
And then he switched that to 3 of PRED.
Yeah.
And the cushion came like cushingoid again on the dex.
Yes. Did you hear that?
But the nice thing
Yes.
about is use the assay then to see what endogenous cortisol.
Yes.
Whereas once you're on PRED, you can't. You've got no knowledge now.
Well, that's not true. You see, you can, because we know that PRED is gone. So if you do a blood test in the morning, then you can measure the cortisol, and then we know PRED there because it's gone.
You really feel confident?
Absolutely certain.
Wow.
And we've got day curves, and it's gone. If you get 3 milligrams, it's undetectable 12 hours later.
Prof, do you think that the prednisolone would be metabolized faster as it is without?
Well, that's a good question. That's a good question, and I mean, she clinically, I'll say she's pretty well, so I don't want to mess with it. But it'd be very interesting to do some bread levels.
So you've upped it, have you?
No, I've just gone through. The thing,
1 gram QDS.
I've upped the. I want to wipe out that cortisol.
It's
And,
only 96. No.
yes,
But I'm really sorry, on 1 gram TDS, it was 262.
yeah.
And
No,
if you're
is that-
going into,
Is that
Well, no,
not
so,
before?
so,
No, that's
so when I
not
saw on the
before.
23rd, 2 days ago, I didn't have the 96, and I thought I loved it. And do you think I took it back down to 1 gram TDS?
yeah.
Yeah?
I mean, if you want to be fair, it's on 3 of Fred anyway, so it's not that she's unsafe, but it's just that, I mean, and I guess you're winning with the potassium because you've given us some spiral, haven't you?
Yes, she's
But
on.
I actually
Yeah.
don't know what. I imagine you do want the endogenous cortisol to be as low as possible. So you're saying you want it to go from 96 to less than 30, effectively.
Yeah, I
And
guess
then
so.
do back the 3.
So
So
you've got an increased risk of renal toxicity the higher you go.
Possibly. But what
At
it
the
is,
moment, I thought, you know,
She's
you
coming
have
every
to
week.
manage on the lowest dose possible.
Mhm.
But I guess what is managed.
the problem is, if she escapes, then that will be bad. She had the other interesting thing is, she had a lot of edema.
now,
Well, she's better now with the spironolactone. I think the
Oh, really?
metarapone worsened the edema because you have that precursor.
It's also like aldosterone.
It's like
And that's
aldosterone.
also what your potassium problem
and the
was,
other
isn't it?
small thing is that we had to stop the indapamide because
Yeah.
hypertensive in the background was amlodipine and indapamide.
Yes, so the
And then of course
indapamide,
she was running a low
Oh, yes,
potassium,
of course.
so we switched that to Spiro, and that probably would have helped her. But
in that gap between the 11 and the 15, I think she got quite bad edema because we stopped the indapamide.
we hadn't
And
started.
we were a bit nervous actually about spironolactone potassium, but actually, with hindsight, it's the right thing. Anyway, we've got to see her every week. So this week she looked pretty well, but what she needs is an operation, I think.
So he's going to come back and see Dr. Martin and Mr. Dalton together next Tuesday.
In that combined clinic.
After the MDT.
And the good thing is that the balloon study worked.
Okay, so just like everyone else who doesn't know this patient, she's got an aneurysm in her pituitary, which is why she got cancelled. How unlucky can you be? And so, unbelievably to me, this procedure, they block the carotid artery and then examine you to see if you get any signs of neuron pathology. And if you do, then they can't do it. And if you
They
don't,
let the balloon down first of all, don't they? To allow your paralysis to resolve.
yes,
That's the
but she
first
did,
thing they do.
yes.
But they blocked hers and she didn't get
and
a
she didn't
stroke.
get a
So
stroke,
that's good.
which means there's collateral basically. Which means they can block the aneurysm, they can cut the aneurysm or block it off or something.
If they had to.
Well, I asked about collateral, and they said it wasn't collateral, it was a circle of Willis or something. It's a circle of Willis.
Collateral.
That isn't, because I said the word collateral, and then someone said the circle said no.
Is
It's
that-
not a collateral, and I thought, okay.
The flow is coming round from the other side. and moving across.
So where we are now is we're entering medically, and we want the surgeons to operate on her safely, and they're going to discuss it next week with her.
Next Tuesday.
They've had a meeting today, have they?
Yes, well, the Harriet could see the neurovascular entry from the radiology meeting, and essentially, Harriet read it with me. Essentially, Harriet, it says it doesn't actually say anything more. It says it's very dangerous. It says a 10% risk of stroke if you stop the. So if you put a flow diverter in,
Yeah.
there's a 10% risk of stroke if you stop the anticoagulation. And I can't remember if that was stopping it all or going down to 1, because you remember, even if they flow divert it and wait 6 months,
Yeah.
they would still not want to operate with her on aspirin for a few days. Let alone aspirin.
Yeah, there is-
Go on, Debbie.
I was going to say that the discussion is pretty much the same as the discussion we had in the pituitary MDT, isn't it? On the
Right.
from the neurovascular one.
Okay. Just incidentally, what in someone who has got an aneurysm, another patient they operated this week, and she's done pretty well.
She has, but there's obviously a bit of residual around
Yeah.
the aneurysm.
Yeah. Okay. Any questions from anybody else?
You actually do want to know with block and replace whether you track if you block, like block and replace the grades, you just put them on the 40.
Yeah.
And then 6 weeks later, you put them on the thyroxine and you're done. And if the thyroxine's not quite right, you go up and down on the thyroxine and that's it.
Yeah.
Block and replace with Cushing's. If you're going to decide to block and replace everyone, I haven't done enough to know whether you, at what point you've blocked enough to then add in the prep.
You see,
And different people do different things.
Yes, I got the impression that it was a bit like, so once you've gone to 1 gram TDS, presumably you don't, did you look at endogenous cortisol before you gave her pred, or you just gave her pred?
Well, when it comes to obviously the nervousness causing an hallucinating crisis, so I thought we'd just started there. Because if she has a crisis, that would be a disaster, wouldn't it, really, in every way, on Metaropone.
So in other words, you didn't wait for endogenous cortisol, you gave her prednisolone as soon as
I presume, yes, you're right. You're right.
Which is fine, I'm not, I
You're
think
right.
that's how I would feel too, but I don't know what other people do, I don't know what people do.
I suppose, Florian, you there? Nathan, he's. So it's a good question. I mean, the thing about thyroid is it's not that the risks are not so huge, are they?
No, I understand.
So just to get it slightly wrong,
I
it's
think
all right.
lots of people, I don't know if I'm right. I think lots of people just block and replace and just do it. So you go like you go 1 gram TDS and then check the cortisol 2 weeks later and add in your pred and off you go. But if the cortisol's below, if you want it below, if someone can't go around with a cortisol of less than 50.
Exactly.
Very long without feeling well.
And the other problem with the gram, so there are some people, you know, we start slowly and work up like this. That's the problem. You get 500.
Pituitary will escape more than adrenal.
Yeah.
People behave differently.
It's
Well,
a,
we can go to, we've definitely had someone in the past who had renal dysfunction with the thyroid.
Yes.
So I guess that's why I was coming back to, not everyone needs 1 gram TD, you know, you
Okay.
might have something with 250 milligrams at night.
yes.
Of mild disease, and actually then you don't need to worry about the side effects as much.
Yes. Basically, the 250 at night, I'm guessing, is to try and give a bit of a circadian rhythm. And maybe at night is the wrong time, because at night, a bit early, because it takes a few hours to work. So I'm just making this up. Your presumption is 6 p.m. might be the optimum time, but as Harriet says, we need a day curve. We should do one. Not on this basis, because she's on too much now. Okay.
You mean Metaropone at 6 p.m.
6 p.m. and then do a day curve to see if it works. If it works.
Night curve.
And day and night curve. A day and
Thyroid 3 times a day, so it must be working
8 hours.
within 8 hours.
Yes, I think the issue though is we give it 3 times a day to completely have a fixed level. Because up to now, our guideline has said, bring it down to 150 to 300, which is what everyone does. But that's not circadian, is it really? That's flat.
I think personally, if I had pituitary Cushing's, I wouldn't be so fussed about having this because of circadian. I want to be safe. So that's been for the right reasons. You want to be enough cortisol.
Yeah.
You're not going to be completely wiped out, and also there's all that risk about exposure to atypical infections and stuff. It really drops because you need a bit of steroid around running off. So I think the more I think about it, I can see how block and replace you feel is safer.
That's exactly my thinking too. I started off thinking, let's go for circadian Metaropone, and then it's so different. Because you don't get any blood tests, so it's impossible, in fact, isn't it?
But outside COVID,
Yeah.
I don't think John Neal Price was possible facing everyone. I think maybe that was
Well, all of
people frequently.
so the other problem outside COVID is everyone gets surgery very quickly. So this is an example of a delayed surgery because of an aneurysm, which is a bit unusual. It's very okay. Anyway, we're carrying on, so we'll have to see how that goes. Thank you, Deb. You want to keep going?
So the next
But wait a minute, sorry. What?
We're just thinking you may only need 1 gram.
Okay, look, I'll tell you what. So we'll do a cortisol when she comes to clinic next week, and if it's really low, we'll cut back to TDS.
basically how she's
And that, and that.
And a pregnant.
Yes. Yes, thank you. Okay.
Okay, shall I carry on?
Yes, please.
Okay, so the next lady is a 34-year-old lady, non-smoker, she's not an alcohol drinker. She was originally admitted back in May with a sudden onset of severe left-sided headache. She had a complete left-sided ptosis and transient diplopia, which resolved. And she had pituitary apoplexy on imaging. She had a history of a 46-kilogram weight gain over the previous year with worsening acne and silver striae. On examination, she was found to have large body habitus with a moon face, acne scarring, moderate hirsutism. Both of these patients had used, so this lady used laser hair removal and the other patient had used creams for their hirsutism. She had a left eye ptosis, she had silvery striae on her abdomen, and she confirmed that they had developed over the past 2 years, not during her pregnancy. They weren't violaceous or tender, and she had difficulty rising from squat. She had multiple bruises on both arms, and she reports bruises very easily and had a buffalo hump. Interesting, this lady was investigated. She had a dexamethasone suppression test quite a few years earlier when she saw, she was seen in our endocrine clinic and she passed that. So these are her initial investigations on her admission. That cortisol of greater than 3,000 was probably because she had parenteral hydrocortisone in A&E. On the 11th, 13th and 14th, she had sufficient cortisol levels. She was discharged home on the 11th and prednisolone was stopped. She was started on prednisolone initially in hospital. And then she was readmitted on the 13th of May with a headache and visual loss. And she was discharged soon after that. She was only in a day or so. 14th of May shows her cortisol is 276. Her ACTH at that point is 66.4.
So this is 1 week after she had, is that right? When did she have?
Yes, about that. Yeah, that's the week after she was originally admitted.
Okay.
The 14th. And so once she was discharged on the 14th of May, she had an overnight dexamethasone test and the cortisol only got to 155. On the 17th of May, she had a cortisol day curve. And by that time, you can see her cortisol levels are quite a bit different.
You'll see that 72. So they're all under 100 for the whole day.
Yeah, and she was started after this on 3 milligrams of prednisolone.
It's fascinating, isn't it? It's a really interesting.
She went on to have subsequent day curves.
So in the 21st of May, she must have stopped the pred that day.
I'll let you digest those. Yes.
Yeah.
She stopped that. She didn't have that on the morning. And then she had a repeat on the 16th of June. And at that point, the prednisolone was stopped.
Okay.
And then she had subsequent ones. And then following this September one, she had a low dose dexamethasone test.
Okay, so you can see then that the day curve is slowly getting, I mean, that's this June one, the June ones look normal. And in August, it doesn't look normal. That it's got the late numbers are rising. So it's 409.
Nothing's normal with that background, is it? No, she had a pituitary.
Yeah, no, but okay. But she's got, okay. But there is normal. It's a circadian rhythm. Well, they haven't got midnight.
You need a midnight. And it's not
okay, so shall I go on to the next slide to see what's it?
Yeah, and then you can see on the 13th of September, which is 3 months ago, that it looks pretty awful now. It looks like proper flat. It's not flat, it's still high in the morning.
Every morning one is significantly higher.
It's climbing. And
yeah.
But the 6 p.m. one on the 13th of September is not looking good. Okay.
Okay. So on the 4th of the 10th, this was a 48-hour low dose, and she suppressed to 100. She was seen in clinic, and it was decided she'd have another day curve and then to commence metirapone. So the first one on the 18th, this is her on nothing, and then on the evening of the 19th, she had metyropone at 6 p.m. I think she had 500 milligrams the evening before, and then the day curve the next day.
On which day?
So she took the metyropone on the 19th.
Yeah.
And then she had, I think these different to the slides I probably didn't say it properly. I put dose in. So on the 19th, she took metyropone, and on the 20th, she had a day curve. So she took metyropone at 6 p.m. on the 19th, and then this is the day curve on the 20th.
Why did she have that done?
I was doing what we were talking about, which is to try and get us. Okay, the problem is we're missing the one we need, which is the midnight.
I think that's here.
How well the metyropone
Midnight cortisol on the 1st of November was 183.
Yeah. Okay, and was that after a dose of metyropone at 6 p.m.?
No, that was before.
Yeah. So, okay.
I don't think she's quite. So she started metyropone regularly on 750 once a day regularly on the 2nd. And then here we've got some salivary cortisols that she had done in September and October. And then she had a repeat cortisol day curve on metyropone taken at 6 o'clock the previous day.
But we've not got midnight.
That was 70. The midnight cortisol was the 183.
No, but that was not on metyropone. What I mean is she needs the midnight to see if the metyropone works.
She might have been on metyropone. I'm not clear. I would need to go and check. I've got 10 months notes.
Yes, and also, as Emma's pointing out, the midnight is a bit high. So she, so it's not enough, is it?
Exactly.
So you're going to put her on twice a day metyropone?
I think we have to. And so should we give it to her at noon and 6 p.m. then? Would that be a good way to try and get some? We could either block and replace. Priscilla, your hands up.
Yes, I think the midnight cortisol Debbie was on metyropone because that's what I instructed them to do.
Yes, yeah.
So she came on the first. So she had that was the whole point of doing it. So she came on the first.
Yeah.
Had it at 6, had a midnight cortisol overnight, and then on the 2nd she was discharged on regular dose of 750.
Okay. So Emma's pointing out that we should give her a dose at noon. You see how it goes up at 3 p.m. So if we are going, I don't think it's right, but one option is to go for a bit of a circadian and give her 2 doses a day, one at noon and one at 6 p.m. and then do another day curve.
Why wouldn't we go straight for block and replace now in this lady?
That is a good question.
Well, have we done she's had a test, she had a dynamic test showing that she doesn't suppress her cortisol. I know she's Cushing's, but I remember that.
Yes, she's definitely a Cushing.
Have we done that low dose recently?
Yes, she's had a 48-hour low dose.
Okay.